Hello, everyone. My name is Ahmed. I'm a third-year pathology resident, and today I'm going to be talking about acute erythroid leukemia. This entity is defined as a neoplastic proliferation of erythroid cells with features of maturation arrest that would result in increased pro-erythroblasts and a high prevalence of biallelic TP53 alterations. And we use the term alteration because these alterations may include mutations, may include deletions, and may include other stuff as well. This neoplasm can arise de novo. However, it often arises after cytotoxic therapy or as progression from a prior neoplasm, particularly MDS, myelodysplastic neoplasm. The pathogenesis includes aberrant expression of transcriptional regulators like SCI, ERG, and CBFA2T3, and these are linked to erythroid differentiation blockade, resulting in an increase in pro-erythroblasts. Morphologically, these cases show hypercellular marrow, and the bone marrow aspirate smears show overall erythroid predominance, usually 80% or more of marrow cellularity, which includes increased immature erythroid cells, at least 30%. And these immature erythroid cells include pro-erythroblasts or pro-normoblasts. Immature erythroid cells generally show deeply basophilic and agranular cytoplasm. Cytoplasmic blebs and vacuoles are commonly seen, but this is not a specific finding because you can see that in other types of blasts. For example, you can see that in megakaryoblast, you can see that in monoblasts, and you can see that in lymphoblasts as well. Erythroid precursors at later stages display prominent dysplastic features, including ring sideroblasts, and this megakaryopoiesis is frequently present. So in this entity, you can see both erythroid dysplasia as well as megakaryocytic dysplasia. As for the immunophenotype, pro-erythroblasts are positive for CD36, CD71, and CD117. CD117 is usually positive in a subset of tumor cells only. Pro-erythroblasts are negative, usually for CD34 and myeloperoxidase. CD235A, which is also called glycophorin A, is positive in a subset of cells that often correspond to the CD117 negative subset. So the CD117 negative cells are usually positive for glycophorin A. Neoplastic proerythroblasts may show aberrant CD13, increased CD4 expression, or decreased CD38 expression. CD71 is a pan-erythroid marker that stains nucleated erythroid precursors at all stages. However, CD71 is not a specific marker and can stain other cells. Generally speaking, CD117 and ECA adherent often only highlight pro-erythroblasts at early maturation stages, and glycophorin A only highlight late erythroid cells, including mature enucleate red blood cells. And finally, detection of mutant p53 patterns by IC immunohistochemistry is helpful. The essential criteria to make the diagnosis include erythroid predominance, usually 80% or more of bone marrow elements, of which 30% or more are pro-erythroblasts. The differential diagnosis includes reactive erythroid hyperplasia with a prominent erythroblast component in nutritional deficiency and hemolytic anemia, and nutritional deficiency like vitamin B12 or folate deficiency. However, in these cases, from the clinical presentation, you can see that the patient has low vitamin B12 or folate deficiency, and these cases do not show TP53 mutation. Another differential diagnosis includes exuberant erythroid hyperplasia that is seen in some MDS cases. However, in these cases, there is no maturation arrest and increase in proerythroblasts of 30% or more. Another entity to consider is myeloid neoplasms post-cytotoxic therapy, and it's indicated in the WHO book that This should be designated as myeloid neoplasm post-cytotoxic therapy if it's arising after cytotoxic therapy. And lastly, the last differential diagnosis is acute myeloid leukemia, myelodysplasia related on the basis of complex karyotype. Acute myeloid leukemia, myelodysplasia related is an acute myeloid leukemia that has either a specific genetic mutation or a specific cytogenetic abnormality. One of the cytogenetic abnormalities that qualify to make this diagnosis are complex karyotype. So there is this overlap between acute myeloid leukemia, myelodysplasia related, and acute erythroid leukemia. But remember that acute erythroid leukemia diagnosis always supersedes a diagnosis of acute myeloid leukemia, myelodysplasia related. And that's because of the prognosis of acute erythroid leukemia. It has a very poor prognosis. Also, to make a diagnosis of acute myeloid leukemia, myelodysplasia related, you need the presence of at least 20% blasts, myeloblasts. There are some rare cases in which you have 30% or more proerythroblasts and 20% or more myeloblasts, and the classification of these cases is unclear for now. However, remember, acute erythroid leukemia diagnosis supersedes a diagnosis of acute myeloid leukemia, myelodysplasia related. A desirable criteria for the diagnosis is evidence of TP53 mutation. This is the end of this video, and see you next time.